I'm Steve Harms, your host on this breast MRI interventional presentation. I'm a practicing radiologist at the Breast Center of Northwest Arkansas and medical director of Aurora Imaging Technology. Breast MRI is the most sensitive method for detecting breast cancer and often finds disease that cannot be seen by conventional imaging methods such as mammography and ultrasound. Interventional breast MRI describes a group of procedures that may be guided by breast MR images. These procedures include localization of lesions prior to surgery, either with wires or markers, MRI-directed biopsy, either vacuum-assisted or core, and MRI-directed therapy such as laser, RF, or cryo. Aurora makes the first and only dedicated breast MRI system. One of the strengths of this system is that it is designed from the ground up with breast intervention in mind. All components are orchestrated to work in unison to make breast intervention as accurate and efficient as possible. In the past, breast biopsy using a conventional system was time-consuming and problematic. Using the Aurora system, our staff finds breast MRI biopsy to be faster and more efficient than even stereotactic biopsy. I hope that after viewing this presentation, you will realize that MRI breast biopsy can be readily included in your breast imaging practice. The specific advantages of the dedicated breast MRI interventional system are comfort, a dedicated table and spacious magnetic bore, access, more room for intervention and access to the breast, uniform stabilization, a unique compression paddle technology, integrated imaging and lesion targeting. This is enabled through the scan console, a variable needle trajectory, efficient, accurate needle placement, rapid needle marker target confirmation, capability of sampling multiple targets in the same session. The Aurora system is designed for breast imaging only. The table provides a gradual ramp from the feet to the head. This avoids the lordotic position encountered on many add-on breast-type coils. A massage table-type head holder is provided for comfort during the procedure. The RF transmit coils are built into the table rather than the magnet bore. This arrangement provides more space inside the magnet to accommodate larger patients and reduce claustrophobia. We have performed procedures on patients exceeding 300 pounds using this system. The magnet and table are designed for breast intervention. Greater access is needed to access the entire breast. The design accommodates all sizes of breast. So far, we have not seen a breast that could not be scanned or subjected to biopsy. There's plenty of room to work and visualize the interventional work field. Cleanup is easy since the tray edges are designed to contain any fluids that may spill. Breast MRI is unique compared to other biopsy approaches in that the lesion often enhances with contrast and a few minutes later vanishes into the background. If the target moves either by patient movement or inadvertent movement by the procedure, it may not be recognized and the target will be missed. In X-ray stereotactic biopsy, post-fire images can be obtained and specimens can be scanned. In ultrasound, the target can be scanned as the biopsy is performed. With MRI, the target is often only seen on the immediate post-contrast images and fades into the background by the time the needle is placed. For this reason, breast immobilization during the procedure is of paramount importance. Aurora has designed special immobilization paddles that provide the necessary uniform stability as well as comfort for the patient. The medial and lateral paddles have 1 centimeter diameter grid lines. When the breast is compressed, the skin protrudes from the holes, with the grid lines pressing inward, increasing stability in all 3 planes. In this example, the paddle is pushed onto the Play-Doh, and you can see the Play-Doh protruding through the holes. Try to move the Play-Doh in any direction, and it will not move because the grid ribs provide three-directional stability. When the paddle is removed, you can see the imprint on the Play-Doh. This imprint is also seen on the patient's skin. Compression in mammography is designed to conform the breast to a uniform thickness for better X-ray exposure. Compression is not the goal with MRI, it is breast immobilization. Breasts are cone-shaped, with the posterior being larger than the anterior. Yet most compression devices move paddles together in parallel, similar to mammography. The posterior part of the breast is compressed too much and may even be painful, while the anterior part of the breast may not be compressed at all. To account for the high variability in breast sizes and configurations, while maintaining optimal immobilization, both the medial and the lateral Aurora paddles are hinged so that the angles may be adjusted for the patient's breast size. Uniform compression from posterior to anterior is achieved with excellent patient comfort. These paddle angles are shown in this axial image of a patient prior to biopsy. The immobilization paddles have about twice the access of add-on breast MRI biopsy devices. Medial approaches are possible. The immobilization paddles extend far posterior so that posterior lesions can be targeted and sampled. We have done patients with posterior lesions that could not be accessed by stereotactic biopsy. In this patient, an area of segmental enhancement is seen on the projection image. As we change the image to view the thin sections that are moved and rotated through the enhancing segment, we see branching enhancement typical of ductal carcinoma in situ, or DCIS. The mammograms were reviewed and no abnormalities were seen in this area. A second look ultrasound did not reveal a target for a biopsy. As a result, an MR-directed biopsy was indicated for histologic sampling of the incidental enhancing lesion seen only on MRI. The final pathology of this lesion confirmed the presence of DCIS. You may be surprised that MRI could see DCIS when it was not seen on mammography. However, only about a third of DCIS incidentally picked up on pathology is calcified, yet 90% of DCIS seen on mammography is calcified. As higher resolution MRI becomes available, MRI-directed biopsy will have an even greater role in the future. The Aurora breast intervention system is placed into position within the breast coil on the appropriate side. The patient gets on the table in the prone position with the breast undergoing the procedure hanging dependent in the breast coil. The immobilization paddles are adjusted for optimal position for this particular patient. Pre- and post-contrast images are generated. The target is spotted on the scan console images. The cursor is moved over the target. A right mouse click initiates a dialog box. Select the lesion target. A green box appears on the images marking the lesion. The images are reviewed again to find the crosshairs of the fiducial embedded in the biopsy stage. Superimpose the mouse crosshair over the fiducial crosshair on the image and right-click. The dialog box appears where the fiducial is selected. A red box appears on the image marking the fiducial. Now click Biopsy. Another dialog box appears where the needle type is selected. Most commonly available biopsy and localization needles are programmed into the biopsy software. There are 4 needle guide arm positions. Usually the appropriate location of the guide arm is determined by the location of the lesion on the diagnostic images performed prior to the biopsy. If the arm position was incorrectly chosen, no problem. The software will tell you to change it to another arm position. Medial, lateral, superior, inferior, anterior, posterior, stage position numbers are calculated. You are now ready to position the stage. The Position Display Unit, PDU, provides numbers corresponding to the stage position. Match the PDU settings with the numbers provided on the scan console. The superior-inferior, left-right, and anterior-posterior adjustments are made with interactive control. The stage is now centered on the target. The sterile needle guide is now placed in the needle arm. Needle guides are specifically manufactured for each type of needle. These are available for most commonly used vacuum-assisted needles and localization needles. One of the unique features of the Aurora needle guide is its ability to vary the trajectory of the needle. The software targets the center of the chamber assigned on the image. The needle guide can be swiveled in an arc so that the entry point can be changed, but the center of the chamber remains on target. This system allows movement away from the grid of the stabilization paddles should it fall into the trajectory path. It also allows movement away from previous scan defects. Posterior lesions and superior or inferior lesions may also be better sampled with a different trajectory. Local anesthesia is applied. In this example of a vacuum-assisted biopsy, the introducer needle is placed through the guide. You do not need to separately determine the needle depth. In the Aurora system, the needle depth is calculated during the software targeting. The cutting obturator is removed and replaced by the plastic obturator. The patient goes back for a quick T1 scan to confirm the appropriate introducer placement. Images show the low-intensity introducer tip within the green box that was placed on the targeting scan. The AuroraBiopsy software remembers and displays the location of the target in green on all subsequent scans. You can quickly and visually confirm that the needle tip is in the appropriate location for biopsy. If the needle is off-center in the slice direction, the box gets smaller as you move away from the target in the slice direction. You are now ready to sample. Multiple samples are taken with the vacuum-assisted biopsy device. Now we are ready for target marker placement. The biopsy device is removed and the marker is placed through the introducer. The introducer is removed and a set of images obtained to visualize the marker. Notice that the green box remains on the post-marker images to help determine the location of the marker relative to the target. If the marker is off-center, the location relative to the target can be reported so that this can be addressed at the time of surgery. Multiple targets in the same breast can be serially addressed. For a second location, new PDU numbers are provided for the next target and the stage moved to the next position. This is helpful to allow multiple biopsies of different locations or to provide localization that can bracket a lesion such as DCIS. In this example, we will first target the posterior margin of the DCIS. The fiducial is identified. Then the EZM needle and wire are selected. The anterior part of the DCIS is then targeted. The EZM needle and wire is again selected. You can then serially place the needles and confirm position, just as in the biopsy introducer example. In summary, Aurora provides a complete integrated solution for breast MRI intervention. This system combines the following advantages: patient comfort with an integrated table and a larger bore magnet. Access, more to the breast is accessible. Medial and lateral approach is possible. Uniform breast stabilization. Integrated acquisition and targeting. Variable needle trajectory. Efficient needle placement. Rapid needle marker target confirmation. Capability of sampling multiple targets in the same session. Now you have seen how accurate and efficient breast MRI intervention can be achieved using the Aurora dedicated breast MRI system. We hope that this presentation has helped you to plan for the implementation of MRI-guided intervention in your practice.